the guideline on the first trimester ultrasound and the second trimester ultrasound, but we did not have a guideline on the third trimester ultrasound. And in fact, most organizations do not have a dedicated guideline for the third trimester ultrasound. So I'm really pleased that we are publishing this in a wide journal, and I really hope that you find this useful. I think it's important that we try to move away from the fact that the third trimester ultrasound is just a gross scan, and we go to the approach of a checklist. And the checklist that's proposed in this guideline include the viability, the assessing the placenta location, the fetal presentation, the biometry, looking at the fetal gross amniotic fluid volume, and the Doppler when needed, and the fetal anatomy. And in fact, this is the various views that you would expect to obtain in this ultrasound scan. And of course, there may be certain views according to the background or the risk, or if the woman had a low placenta or placenta previa with a previous cesarean section, so you might want to look at the signs of placenta accreta, or have risk factors that you need to look for Vasa previa. If we are doing a routine third trimester obstetric ultrasound scan, what gestation should we perform that? Well, it depends really on the purpose of this ultrasound scan. It would be different if you are looking mainly at detecting anomalies in the third trimester, or actually assessing or looking for gross abnormalities, or looking at mainly for biometry. So it's a trade-off between the optimal visibility of the fetal anatomy, which obviously would mean that we need to perform it at an earlier gestational age, and the accuracy of the fetal gross assessment, which we know from the data that tend to be more accurate the later the gestation. And therefore, if our primary goal is to assess or to screen or detect fetal gross abnormalities, in this case, the gestation age should be between 35 and 36 weeks plus 6 days. While if we actually want to look at anomalies, and that obviously depends also on the risk factor or risk profile of this pregnancy, in this case, we would aim to do it at 31 to 32 weeks plus 6 days. And the evidence to back up in terms of the gestation for the biometry is the fact here that we know that the later the ultrasound pregnancy, the more accurate in detecting whether small for gestational age or large for gestational age. And you see this from this data, to the area under the curve, so detecting small gestational age, if you use the estimated fetal weight here, the 35, 36, or 37, 31 to 33 plus 6, and you see the area under the curve is higher if the ultrasound scan performed later compared to earlier, and the same applies for the large for gestational age. And therefore, based on that, the recommendation and the guideline is that at the timing of the third trimester scan, if indicated, between, and this, if you're in gestational age period between 32 and 36 weeks, should be decided based on individual maternal and fetal characteristics. If the woman had a previous history of a small baby, for example, or a large baby, the risk level of the pregnancy, and the particular risk factors, and the local objectives, and the resources. How to determine gestational age using ultrasound in third trimester? Well, ideally, this pregnancy would have been dated earlier, and the most accurate dating is using the crown outlines in the first trimester. And that gives us an accuracy within 5 days. And certainly if this pregnancy has been dated in the first trimester, we strongly encourage you not to change, not to redate the pregnancy in the third trimester. But what about if the woman presenting for the first time in the third trimester? In this case, we should determine or calculate the gestational age using the head circumference plus female length, or the head circumference alone if the female length is not available. But even using this methodology still is not very accurate. There's a variation of about 15 days around the mean at about 32 weeks. And certainly in the later gestation, when the head is quite even, or sort of low in the pelvis, it's actually really difficult to get accurate measurement of the head circumference or the BBD. And therefore, certainly in my own practice at St. George's, we tend to, if we do that, we tend to bring the patient back in about a couple of weeks to ensure that we don't miss a small baby or a baby that's cost-restricted. Assessment of the placenta in the third trimester, and that would address three conditions: the placenta previa, the vasa previa, and the morbidly adherent placenta. And certainly assessment of the placenta location should be a component of any ultrasound scan performed in the second or the third trimester. So even if the ultrasound was done in the third trimester, and I sort of mentioned that it's high and the patient presenting with vaginal bleeding, still we should really look at the placenta. So it should be a component of the third trimester ultrasound. And certainly if a woman had a low-lying placenta or placenta previa in the second trimester, you should have obviously follow-up assessment for in the third trimester. And if the woman had placenta previa or uterine scar, in this case also the section, we need to probably arrange the ultrasound scan earlier, so 28 weeks, because you want to see whether this is it remains as a placenta previa and look for the signs of placenta, morbidly adherent placenta, in case this woman comes with major bleeding, and in terms of the surgical preparation. But if the woman is minor placenta previa, it's maybe assessed later in the third trimester. Do we do transabdominal, transvaginal? We know the transvaginal approach is preferred in cases of suspected, particularly the posterior placenta previa, and that's supported by the data. Moving on to the vasa previa, which is the presence of unprotected fetal vessels, whether arterial or venous, that traverse the membranes overlying the cervix, and it has a very high perinatal mortality, more than 50% when it's not diagnosed. But when it is diagnosed, survival is almost 100%. And also the fact that we know that transvaginal ultrasound scan with combined with the Doppler have very high sensitivity, 100%, and again almost 100% or 99.8% specificity. So the question, should we really routinely screen for vasa previa? And the answer is it's quite controversial, and in fact, certainly most guidelines do not recommend routine screening for vasa previa. And the rationale behind that is the fact that there are known risk factors, and in fact, about more than 80% of vasa previa, they have already one or more risk factors. And these risk factors, you can see there, whether placenta previa, low-lying placenta, bilobed placenta, accentuated lobe, multiple pregnancy, IVF, conception, or abnormal cord insertion. So if you have these risk factors, you really should look or exclude vasa previa. Does vasa previa resolve? And if so, how often? Well, yes, it can. And that happened in about 23% of the cases that would resolve between the second and third trimester. And how do you actually define, what do you mean by resolve? Well, the resolution of vasa previa is defined when the distance from the internal cervical os is more than 20 millimeter, and it depends on factors, sort of the location of the placenta, gestational age, and the presence of the placenta of the vessels. But when the vasa previa identified an early scan, it's important that we follow up or we do the reassessment in the third trimester. And therefore, the recommendation, the guideline, was the fact that in the presence of risk factors for vasa previa, we need to perform a targeted examination using a transvaginal approach, obviously combined with Doppler, to look for vasa previa. And when vasa previa identified earlier in pregnancy, so in the second trimester, we need to make sure that we do reassessment in the third trimester, because in about more than 20% of them resolve. The morbidly adherent placenta, we need to, of course, avoid the false negative, and certainly people will probably prioritize avoiding false negative because of the consequences and the maternal risk of maternal morbidity and the need for surgical planning and including multidisciplinarity. But I also think it's important that we should try to avoid false positive because of the iatrogenic prematurity and the fact that, the anxiety associated with the diagnosis, and also the potential iatrogenic preoperative invasive procedures, which can be resulting complications. I'm not going to go through in details ultrasound signs of the placenta accreta spectrum, because that's already a separate subject of another guideline in the pipeline. But certainly you can divide them into gray scale and the signs that you look at with the color Doppler And there are several papers highlighting the accuracy of these individual signs, but also the false, also of the technical precautions where you're actually looking at the signs. But certainly when we put in this guideline, the third trimester ultrasound guideline, is that if you have a placenta previa and prior cesarean section or uterine surgery, so for example, myomectomy, that this pregnancy should undergo a detailed ultrasound assessment to rule out placenta accreta spectrum. And irrespective of the ultrasound findings, if you have a placenta previa with prior cesarean birth or uterine surgery, this pregnancy should be considered as a potential case of placenta accreta spectrum and managed in a center with required expertise. What about the role of the MRI? The MRI should be considered not necessarily in all cases, but in cases where there is the placenta accreta spectrum is an uncommon location, for example, lateral wall of the uterus or posterior wall, and the MRI may be considered in case of inconclusives if your ultrasound scan is not certain or there is particularly suspicious of parametric invasion. And the longitudinal assessment of fetal growth is not necessary in these cases because actually placenta accreta spectrum is not associated with problems in fetal growth. What about the presentation, the fetal presentation? Well, we know that about 3 to 4% of babies present in breech by the end of the pregnancy, and about 1/3 to half of them are only detected when the mother presents in labor, and that can result or associated with maternal infant morbidity and mortality. So routine or universal late pregnancy ultrasound scan has been shown to reduce the risk of undiagnosed breech in labor and reduce the risk of perinatal mortality and morbidity. And this is a paper that we published in 2023, where demonstrating that the implementation of routine third trimester ultrasound scan reduces the chance of undiagnosed breech at term. And that was before the implementation, after the implementation from 14% to 3%. So about 70% reduction of undiagnosed breech, but not just the undiagnosed breech, but also the chance of low Apgar scores, 80%, about 70% of hypoxic ischemic encephalopathy, and nearly 80% reduction in perinatal mortality. So not just the undiagnosed breech, but also the important outcomes. And therefore, our recommendation is that, yes, routine third trimester ultrasound scan is associated with a reduction in term undiagnosed breech presentation and with an improvement in neonatal outcomes. What about gross abnormalities? Well, as I showed you earlier, the later the ultrasound scan in pregnancy, the more accurate in detecting large for gestational age. Here, the area under the curve, and you see if you compare the gestational age window between 35 and 36 plus 6 days, compared to 31 plus to 33 weeks, you see that the area under the curve is higher. So that's definitely the later. In fact, actually, if you do the scan within 10 days of the delivery, it's even far more accurate. But do we use estimated fetal weight or do we use abdominal circumference? And the data suggests that actually the estimated fetal weight is better than abdominal circumference for detection of large for gestational age, 0.9 compared to 0.882. So screening for large for gestational age is more accurate when examination performed at 36 rather than 32 weeks. Later, the better. And then obviously the big question, the elephant in the room, is that what do you do to these pregnancies? Do you manage them expectantly? Do you plan early delivery, induction of labor, or cesarean section? And the evidence in this area has been controversial, but there is evidence from randomized controlled trials support the offer of induction of labor to perceived macrosomia. And that's mainly for the risk of shoulder dystocia and fractures. But also, on the other hand, there is this potential adverse effects of early term delivery. So it's something that healthcare professionals should consider. What about for the small for gestational age? Again, it's more accurate when examination performed later than earlier. I showed you this data before. For small for gestational age, it seems that maybe estimated fetal weight and abdominal circumference can be used to similar performance, but again, the data can be controversial. What about amniotic fluid volume? do we use the assessment or diagnosis of polyhydramnios or oligohydramnios to use it based on amniotic fluid index or the deepest vertical pocket? And in fact, interestingly, the evidence suggests that for polyhydramnios, it's better to use the AFI, while for oligohydramnios, it's better to use the deepest vertical pocket. So commonly used interchangeably, but based on this data, the positive data value for low volume was higher using the deepest vertical pocket compared to the amniotic fluid index, while the positive data value for high volume was better for the AFI compared to the DVP. So the DVP is superior for identification of oligohydramnios, and AFI is superior for identification of polyhydramnios. So for the diagnosis of polyhydramnios, AFI 25 centimeter, DVP 8 centimeter, and I said the AFI seems to perform better. There is the degrees of severity of the polyhydramnios, and that depends obviously on various cutoffs of the AFI or the DVP, mild, moderate, severe. And why would that be important? Well, because in fact, the likelihood of underlying condition, it is associated with the severity. So the more severe, the more likely that you identify or find an underlying condition. 90%, moderate polyhydramnios, only 17%, mild polyhydramnios, and of course we need to know the technique how to measure the deepest vertical pocket or the AFI. And the number of causes of polyhydramnios that we need to rule out once you have a case of polyhydramnios, including obviously diabetes, which is about 20-25% of the cases. But it's important, the rest of them are actually relying on us as a fetal medicine specialists or sonographers, is that looking for fetal abnormalities, so doing detailed ultrasound scan, looking, and the abnormalities that could be associated with polyhydramnios in the third trimester will be gastrointestinal obstructions, cardiac abnormalities, CNS abnormalities, but also look at the placenta, because if you have placental tumor like cholangioma, fetal infection, rare to cause polyhydramnios without associated features like small baby, for example, or congenital condition that result in anemia and hyperdynamic circulation that can result in polyhydramnios. Chromosomal genetic disorders, and idiopathic, which is actually about more than half of the cases of polyhydramnios. But it's important that idiopathic is a diagnosis by exclusion, as you have to rule out or test for other causes. Is it benign to have polyhydramnios? And the answer is no. In fact, if you see the polyhydramnios associated, this is also ratios with intradermal 7.6, about nearly 8 times the higher the risk. Near to this, 8.7. And then your admission twice, macrosomia 2-3 times, the infection twice the risk. And therefore, when you have a case of polyhydramnios, you need to obviously arrange testing for diabetes, do the detailed ultrasound scan of the fetus and the placenta, looking for anemia, so the MCA bit study velocity, looking at the results of the previous screening or infection. And as I mentioned, idiopathic is a diagnosis exclusion, but the amnio drainage, majority of cases of polyhydramnios don't need amnio drainage except at home symptomatic, so she's very uncomfortable or have dyspnea, and is it counseling this patient about the risk of the complication. And it's important to balance or tailor your risk depending on the what you're seeing on the scan, you're finding underlying cause or not, and how severe the polyhydramnios. Can polyhydramnios resolve? And the answer is yes. In fact, in about 38% of the cases that polyhydramnios was seen or diagnosed in one ultrasound scan, but resolved later in pregnancy. And that's more likely to occur when the diagnosis is made earlier or with a lower amniotic fluid index. And if that happens, if the resolution of polyhydramnios, there's no increased risk of adverse outcomes. Moving on to the oligohydramnios. And the oligohydramnios, if 5 centimeter or less, or DVP 2 centimeter less, and we agreed that the DVP is better to use. And in fact, I showed you a sort of evidence, but there's another evidence, which is a randomized controlled trial where singleton pregnancies had an ultrasound at term, and they were randomized either use the AFI or use the DVP. And the results are interestingly. So if you use the AFI, you diagnose oligohydramnios in about 10% of these pregnancies compared to 2% if you use the deepest vertical pocket. So you diagnose oligohydramnios using EFI compared to DVB. Therefore, you have more induction of labor for oligohydramnios at 10% versus 4%. You have more abnormal CTGs in the EFI compared to the DVB. But actually, there was no really significant difference in the perinatal morbidity or the outcomes. And in the admission, 4%, 5%, not significantly different. So the FI, it seems that maybe overdiagnose oligohydramnios and needing for induction of labor without improving perinatal outcomes. Hence, it's probably better to use the TB's vertical pocket. There are causes of oligohydramnios, including fetal urinary abnormalities, for example, bilateral ureagenesis or obstructive uropathy, being small because of placenta insufficiency, fetal infection like CMV, obviously genetic abnormalities, drug-induced, non-steroidal. The commonest really in the trimester is probably secondary rupture membranes, and still there is possibility of idiopathic oligohydramnios. Again, oligohydramnios, similar to polyhydramnios, is associated with adverse outcomes. So you see those ratios here. The meconium aspiration is about 3 times higher the risk of meconium aspiration, twice the risk of needing section for fetal distress, about twice risk of admission to a neonatal unit. And therefore, some guidelines and certainly a common practice is to offer induction of labor at 37 to 38 weeks for cases of idiopathic oligohydramnios. But there is variation in guidelines. So the American College does recommend, but maybe other guidelines do not. And therefore, there's a variation in practice, but I think it's reasonable to consider offering it. So the recommendation related to that is that DVB is preferred over AFI for diagnosing isolated oligohydramnios associated with fewer induction of labor while having similar perinatal outcomes. The detection of polyhydramnios should lead to a targeted investigation for underlying causes, as idiopathic polyhydramnios is a diagnosis of exclusion. The last section of the that I'm going to include or so talk about in the guideline is the fetal anomalies, the one that detected for the first time in the 3rd trimester. And they could be one of 3 things. It could be because actually they were missed, they were not seen before, and that could be because of a number of reasons, but mainly maybe technical difficulties, the fetal position, maybe the mother BMI, but also sometimes the natural history of some abnormality that they're not really detectable earlier. Or it could be consequent to infection or vascular insults that occurred after the 2nd trimester ultrasound scan. So the fetal anomalies that we detect or see in the 3rd trimester, how common this and what are the types of the abnormalities that are likely to encounter? Well, 3.7 per 1,000, so about 4 in 1,000 women have fetal anomalies diagnosed in the 3rd trimester. The most common was urological, more than half of them, urogenital abnormalities, 15% CNS, about 15% cardiac anomalies. And in this screening study, the women who had a routine ultrasound scan at 35 to 37 weeks, 2% of them had abnormalities. And if you look at the breakdown of this 2%, majority, 70%, were actually abnormalities that were already detected before in the 1st or 2nd trimester. Quarter of them were detected for the first time in the 3rd trimester, and about 7% detected for the first time postnatal. Obviously, the question is that what's the value of detecting abnormalities in the 3rd trimester? And there are a number of benefits why it would be beneficial in improving postnatal outcome. So, for example, planning the timing, the place for delivery. Some of them need to be delivered in a tertiary level or surgical center because the baby might need immediate intervention or maybe need postnatal investigations. Also, nowadays there are the options of fetal interventions, like treating vein of Galen, for example, like putting a shunt or giving medication for certain conditions. But of course, there always also, the potential option of genetic testing, and according to your practice and the law, there's sometimes option of late termination of the pregnancy. So if we're going to do fetal anatomy, what should we look at? And I'm going to go through them relatively quickly. So for the head, the size and the shape. Of course, the microcephaly is diagnosed when head circumference is less than 3 standard deviation from the mean. Should also look at the shape of the head, because in the third trimester we might encounter cases of craniosynostosis. The brain itself, looking at the symmetry, looking at the width, because of the diagnosing ventriculamegaly, looking at the brain itself, the cortex and the parenchyma, because you would be able to detect cortical abnormalities, for example, like recientemente, smooth brain, or polymicrogyria, or agaria, or pachygyria, or some destructive brain lesions, or even tumors. At the heart, almost the same as the second trimester, the size, the symmetry, looking at the four-chamber, the outflow, the three-vessel trachea view, obviously looking at the cardiothoracic circumference in the third trimester is about 0.45, shouldn't be really greater than half of the size of the chest. And it's quite a common finding that you find mild asymmetry of the ventricles. The right ventricle is a bit larger than the left ventricle, and the great arteries of the pulmonary is a little bit larger than the aorta. But again, of course, if you find significant difference, you should refer to fetal echo because of the possibility of diagnosing aortic coagulation. At chest, we need to demonstrate the diaphragm, that both in sagittal and coronal view, because about 20% of CDH cases are detected only in the third trimester. And looking at the lung texture in a transverse view of the chest. The abdomen, the third trimester, you could diagnose things like ascites, for example, calcification, looking for cystic structures, like ovarian cyst, for example, or abdominal cyst. Bowel dilatation is a relatively common phenomenon in the third trimester, but most pathologists actually do with small bowel dilatation more than 14 millimeter. Finally, the urinary system is important to demonstrate the normal appearance of the two kidneys. 60, more than half of cases of hydronephrosis detected in the third trimester, and the upper limit for the anteroposterior diameter of the pelvis in the third trimester will be about 7 millimeter. And certainly, if you have the anteroposterior diameter more than 15 millimeters, a severe hydronephrosis, they have increased risk of needing postnatal surgery. And if you have hydronephrosis, you have to have full assessment of the urinary system, so looking at the ureters, looking at the bladder side, the wall thickness, and the bladder emptying, and of course, amniotic fluid volume. So, and therefore, the basic anatomy evaluation in the third trimester scan should include examination of the head, brain, heart, chest, abdomen, and the urinary system. So you remember when I mentioned earlier, we need to think about the third trimester ultrasound scan. We need to go beyond just a gross scan. Finally, is routine third trimester obstetric ultrasound scan, is it actually recommended routinely? And I said that there is variation in practice, but certainly if you look at the evidence, there's no convincing evidence that routine universal third trimester ultrasound examination in a low-risk population improve either perinatal maternal outcomes. But this is an area of controversies about the quality of the evidence. But I'm going to stop here. Thank you very much for your attention. I really hope that you enjoy reading the article and you find the guideline useful.